Hey podcast listeners, Fawaz Mufti here from West Cecil Medical Center, New York Medical College, and this is another episode of the Neurocritical Care Society podcast. There are currently no therapies proven to promote early recovery of consciousness in patients with severe brain injury. And it's no secret that unlike the kidney or the heart, the brain, and more specifically consciousness, lacks any validated bedside clinical or biochemical marker that can hint towards potential recovery. Clinicians and families are constantly facing time-sensitive life or death decisions. Not infrequently, clinicians may find themselves rendering inaccurate neuroprognostication, which can inadvertently lead to an increased likelihood of denying rehabilitative services or withholding life-sustaining therapies, which in one study actually accounted for almost 70% of all deaths in acute traumatic brain injury. What's the role for neuropharmacologic, electrophysiologic, or even mechanical therapies in neuroprognostication and improving outcomes? And is the future a multimodal approach with limited value attributed to the neurologic exam? Today, Dr. Kronfeld and Dr. Bauerschmidt will discuss with Dr. Brian Edlow a new paradigm for developing and testing targeted therapies that promote early recovery of consciousness in the intensive care unit that was detailed in the recent Neurocritical Care Journal publication entitled Personalized Connectome Mapping to Guide Targeted Therapy and Promote Recovery of Consciousness in the Intensive Care Unit. For the record, I had to Google the word connectome, but trust me, you will learn all about that and much more during this terrific episode.
Hello, everyone, and welcome to the Neurocritical Care Society podcast series. I am Kassi, a neurointensivist and stroke neurologist at Harbor-UCLA Medical Center and member of the NCS podcast series committee.
And I'm Andrew Bauerschmidt, a neurointensivist at Lenox Hill Hospital in New York, also a member of the NCS podcast series subcommittee. Dr. Edlow, thank you so much for joining us. The construct you described in this publication for the clinical design trial is based on using fMRI, quantitative EEG, clinical assessment, and other tools to assess disruption to the subcortical ascending arousal network and cortical default mode network. And this is the foundation for this Connectome clinical trial platform and upcoming study called STIMPACT. And this structured framework using biomarkers seems to be a great way to start achieving the goals of the NCS Curing Coma campaign. Involves both an elegant research framework as well as a proposed specific therapeutic trial to improve recovery from injury. So we wanted to start by discussing the inspiration for developing the Connectome clinical trial platform and how this sets the stage for how to go forward with clinical research. So what do we know so far about how this connectome changes in the acute and subacute phase after acute brain injury?
Thank you so much, Dr. Kronfeld, Dr. Bauerschmidt. I just wanted to also thank the Neurocritical Care Society for the opportunity to participate in this podcast. So thank you for inviting me. As far as how the connectome changes in the acute phase of traumatic brain injury, axonal shearing injury, which is common in these patients, can lead to widespread, multifocal, and heterogeneous neural network disruptions. And there's evidence from imaging and histopathologic studies that traumatic disorders of consciousness are essentially disconnection syndromes, whereby connections within and between multiple networks are disrupted. These disconnections have mostly been studied using structural and functional MRI, which have revealed that the severity of disconnections within certain networks, such as the default mode network that you referred to a moment ago, Dr. Bauerschmidt, correlate with the degree of altered consciousness. And these advanced MRI studies have also begun to show us the network architecture that supports the reemergence of consciousness in patients with severe TBI. If you look at how the biomechanics of traumatic forces, particularly the rotational forces, are exerted on the brain, there are some network components that appear to be particularly susceptible to injury, like the interhemispheric connections of the corpus callosum, and other network components that appear to be resilient and sometimes are unharmed, even in comatose patients with severe traumatic brain injuries. So our lab and others have generated preliminary data showing that one such network component, the ventral tegmental area node in the midbrain, and its axonal connections within the ascending arousal network, this network component appears to be spared from disconnections in some patients with severe TBI. This is one of the main reasons that for our clinical trial, which we call STIMPACT, we selected intravenous methylphenidate, a dopamine reuptake inhibitor that acts on the dopaminergic connections of the brainstem's ventral tegmental area. If these connections are preserved in some patients with severe TBI, then we should be able to stimulate these connections and promote dopamine signaling with this potent, rapid-acting formulation of methylphenidate. Our goal is to identify patients who have these preserved VTA connections using diffusion MRI tractography. This is a technique that maps the structural connections in the connectome based on the directional diffusion of water molecules along axonal bundles. And in our current trial, which is a phase 1 trial, primary outcomes pertain to safety and dose finding. But in the later phases of the trial, if we're able to show that ventral tegmental area connections predict an individual patient's response to IV methylphenidate, then we can ultimately select patients for this therapy who are likely to benefit and avoid exposing other patients to unnecessary risks of side effects. And so this is the foundational premise of what we call the Connectome-based clinical trial platform. The idea that a mechanistic connectome-based approach to clinical trial design and to therapy selection will make clinical trials more likely to succeed by selecting patients who are likely to benefit, and it will also ensure that each patient receives therapies that are targeted to his or her unique connectome.
Fantastic. Some of our listeners may not be so familiar with some of these fMRI techniques, tractography. Can you explain a little bit about just how that's performed and how we actually see connectivity? Because we talk about it in a sort of abstract way.
The acquisition of diffusion MRI data that are ultimately used to create these tractography maps of the human connectome, they are acquired on standard clinical MRI scanners. So the patients don't have to go to any different type of scanner. It's the same hardware that we're used to using for a conventional clinical MRI. The distinction is that the sequence we use, the software that is obtained or performed on that scanner is slightly different. It is higher resolution with respect to the number of diffusion measurements that are made. Once you increase the number of diffusion measurements that are made, you can characterize the directional diffusion of water molecules along axon bundles. And if those axon bundles are intact, the diffusion will remain directional or anisotropic. And you can essentially reconstruct the axonal fiber tracts by looking at the directional vectors within each voxel. And you essentially, it's like connecting the dots. You connect the voxels such that each vector connects to the one next to it, and you inferentially reconstruct a fiber tract, each tract representing about 10 to the 5th axons in the intact human brain. If those axons are disrupted by shearing forces and by traumatic axonal injury, then water molecules will diffuse not just directionally along the axons, but also in a perpendicular direction across the injured axonal membranes, and the overall directionality of water diffusion will be low, and you won't see these directional vectors that are used to reconstruct tracts. So basically, we're measuring water diffusion, using that information to reconstruct fiber tracts, and then making inferences about whether axons are intact or not intact.
Thank you for explaining that. I think that definitely gives a great context for our listeners to understand better this connectome. How do we understand how this connectome changes in the acute phase of injury versus subacute and chronic phases of the injury? Is that something that your work has elaborated on previous to this trial?
So this is a really important question that has not been fully answered in our field. And I'll talk about it a little bit, how it's been kind of explored from a neuroscientific perspective, and then why it's relevant clinically and to the design of clinical trials. So we know that Wallerian degeneration takes several weeks to be completed, and therefore the way that an injured axon might look under the microscope at minute 1 or hour 1 is very different than the way that that injured axon will look a week or a month later. Now, as far as the ability of this technique, diffusion MRI, and the ability of the tractography models that we create to detect hyperacute injury, that's still something that is being explored and isn't fully understood, because if an axon is disconnected hyperacutely within the first few hours or days, and if that disconnection can only be seen on the order of microns, but our MRI voxels are about 2 millimeters, then we might not be able to detect those disconnections, and we might pick up an axonal tract that looks like it's still preserved, even if it's actually microscopically torn. So it is probably much more feasible to identify injured tracts in the later stages of severe TBI, in the subacute to chronic stages, whereas in the acute stage, the findings can be more variable. It's harder to detect injured tracts. And so it remains to be determined when is the optimal time to acquire these data. Should we be waiting 7, 10, 14 days instead of acquiring these data in the first few days? That is an area of active investigation.
Right. That leads us to the other question, which is what kind of data can be acquired kind of more often or continuously, particularly EEG. And can you talk a little bit about some of the quantitative EEG techniques that you're using, and specifically alpha delta ratio? What is it and why was it chosen as a EEG biomarker in this study?
So appreciate this question. As you pointed out, EEG is going to be a key component of our study. It's going to be a pharmacodynamic biomarker that we use to measure the effects of intravenous methylphenidate on these patients. And as you mentioned, we're going to be performing continuous EEG for 5 days. The first day of acquisition will be prior to methylphenidate administration. And the goal there is to investigate baseline EEG rhythms and the baseline variance in the EEG-based biomarkers that will be measured, like the alpha delta ratio. It's important to point out here that there are many candidate biomarkers that can be extracted from the resting EEG signal and that have been shown to correlate with changes in level of consciousness in this patient population. There's some really exciting work coming out of Jacobo Sitt's lab in Paris on this topic, and I would refer your listeners to a recent paper by Dennis Engelman from 2018, in which that lab showed that there are multiple spectral, graph theoretical, and information theory biomarkers that are potential measures of consciousness in this population. And in the early phases of our study, we're going to be performing exploratory analyses on multiple biomarkers like those identified in the Engelman study. The alpha delta ratio we thought was particularly appealing because it relies upon readily identifiable spectral measures that are well established. They've already been comprehensively characterized in our field. And in our preliminary data, as well as data from other labs, we've seen that the alpha delta ratio increases as patients recover consciousness naturally over the course of their recovery. And so we expect that if IV methylphenidate activates cortical networks via dopaminergic signaling from the ventral tegmental area, then this alpha delta ratio should be higher in the immediate few minutes to hours post-drug as compared to the pre-drug baseline EEG data.
And getting into how do we interpret these biomarkers in the acute phase of severe TBI, what considerations did you make on how to address these issues, such as patients that are on sedatives, antiepileptics, and any other clinical confounders like hemorrhage expansion, ICP-related issues? How do we factor this into this type of trial design?
And so a couple of thoughts to share here. One is we're all familiar with the baseline fluctuation in levels of arousal in these patients in the first few hours and days of their ICU stay. And even in the chronic stage, when things tend to have settled down, there was a recent paper by Juanez and colleagues in Annals of Neurology showing that if you want to detect a patient's level of consciousness just based on the bedside exam, a standard behavioral assessment at the bedside, you need to do at least 5 examinations over a course of several days to catch that patient at his or her best. Now in the ICU, I think we would probably all agree that those fluctuations are even more pronounced and more frequent. So it's not really known how often we need to be examining these patients to understand their baseline fluctuation and how we can then measure a drug effect in the context of these fluctuations is something that I think our field hasn't fully worked out yet. So we are well aware of these issues, these potential confounders. They are things that we are actively discussing with our statisticians and trying to incorporate into the study design as best we can. To address your point about sedation, so as I mentioned before, this is a phase 1 safety and dose finding study. We are not looking primarily at efficacy. That would come in later phase trials if we get there. And so we are allowing patients to be on propofol, dexmedetomidine, other types of sedative drips, recognizing that those patients are less likely to show a behavioral response, less likely to show a pharmacodynamic biomarker response with EEG, where we're also doing resting state fMRI on the last day of the trial. But because we're primarily aimed at assessing the safety and the optimal dose, we're willing to accept that we might mask those types of responses for patients who are on sedatives. One other quick thought to mention, I just want to make a shout out here to the NINDS clinical trial methodology course, which I took in preparation for launching this trial a couple of years ago. It was extraordinarily helpful for getting training in basic clinical trial design and also for getting feedback on the specific aspects of the STIMPACT trial. So for any of your podcast listeners who might be interested in getting involved in clinical trials, I would strongly recommend the NINDS course, which I found to be tremendous.
Fantastic.
One of the focuses we had in planning this trial with our statistician, Dr. Andrea Folks, who's the director of the MGH Biostats Center, we try to measure baseline variance, not just hours or days before we give the medication, but in the immediate minutes before we give the medication. And because methylphenidate has a pretty rapid onset, so the half-life is about 2 hours, peak effect in the brain based on prior studies in healthy volunteers is about 10 to 15 minutes. And so if we see a significant change within the first 15 minutes out to an hour or two, as compared to the immediate pre-drug baseline, those are the types of statistical comparisons we're going to be performing, recognizing that we're never going to completely eradicate confounders and the baseline variance.
Taking a little bit of a different tact, I know many physicians who currently use neurostimulants kind of off-label for neurorecovery in the ICU environment, including methylphenidate. Candid question, do you?
Yes. So I and several of my colleagues on the neuro-ICU team at MGH, we do use stimulants off-label in the ICU to try to promote recovery of consciousness in patients with severe TBI. And we actually look back at our data from Mass General and from Brigham and Women's Hospital in a study that was led by our neuro-ICU pharmacist named Megan Barra, who was also a co-investigator on the STIMPACT trial. And Dr. Barra found that stimulants were administered in 8% of our severe TBI patients in our ICUs across both hospitals. So not a large percentage of our population, but still, I think that the use has been growing over time. Amantadine was the most commonly prescribed stimulant in our ICU, far more commonly than modafinil or methylphenidate. So, it's a small percentage of patients. We don't have a ton of experience with it. And we're still trying to understand the side effect profile of these medications in the ICU so that we can carefully weigh the risks and benefits. Thus far, our data and data from a couple of other sites who have published on this suggests that the risks are relatively low. I don't think there have been any severe adverse effects reported to date, but agitation, restlessness, insomnia, these are some of the more common side effects that can be seen in these patients.
Yeah, just thinking about that timing, I appreciate that this study is ambitious and that it's truly looking at this acute phase of injury, because as you also point out in your paper, these conversations of withdrawal of life-sustaining therapy are often happening within the first several days of post-injury. And so we really need these answers much earlier than what other studies have looked at, which is this much more subacute to chronic time frame of giving people different types of neurostimulants, more so when they're in the rehabilitation phase. That could be 3, 6, 12 months out from the initial injury. Was there any thought into how to maybe think about this? If yes, we do need this critical information in the acute phase, but how many days of therapy does it really take to affect these circuits? Is there more utility into following this in a much more longitudinal way into that subacute chronic phase, even though it's starting early, which again is very unique here? How do we really think about this as far as the bigger context during the full rehabilitation of the patient?
So many important issues there, both medically and ethically. So to try to address some of the points that you made, as far as the timing, our goal, our hope, is that whether it's IV methylphenidate or some other type of therapy, that ultimately there will be a therapy that accelerates recovery of consciousness before these life or death goals of care decisions have to be made about whether to proceed with tracheostomy and placing a PEG tube or withdrawal of life-sustaining therapy. If we could give families a clear picture of their loved ones' chances of recovery, not just based upon prognostic models that are being developed by multiple labs around the world, but by therapies that accelerate that recovery so that families can see what that potential really is, can see their loved ones open their eyes, start following commands, start showing the first signs of consciousness. There's a robust literature in the ethics world showing, looking at, for example, Joe Finz's work and others, showing that the early recovery of consciousness is one of the primary determinants of families' decisions about whether or not to withdraw life-sustaining therapy. So these are time-sensitive clinical trials that we're trying to perform as early as possible before the goals of care conversations happen, or before those decisions have to be made. But we also have to be careful that we don't provoke elevations in intracranial pressure. And so in this particular trial, we are not enrolling patients until intracranial pressure monitors are out. And if anybody's had high ICP within the last 24 hours, they're not allowed to get the methylphenidate. So, where is that sweet spot, so to speak, between when the ICP issues kind of resolve and before a goals of care decision has to be made? That's kind of where we're trying to provide this therapy. But some patients, as we all know well, have high ICPs, beyond that time when a decision has to be made about trach and peg. So, the timing issue is a really tricky one. And then touching on some of the ethical issues here, if the medication works, we still don't know if it is going to activate networks and then those networks remain engaged and continue to sustain higher levels of consciousness, or will the effect only be transient? And will these patients have an improvement and then a couple hours later or a day or two later go back to a prior low level of consciousness? If the latter is the case, and if the families say, well, wait a minute, you just showed me this can work, we want you to continue, do we go to the FDA for a compassionate use exception? I mean, what do we do then? Do we continue to give this drug? And if so, and in what capacity? We've convened a patient and family advisory board. Patients who have survived and recovered consciousness enough to be able to speak and interact with us, families, loved ones of patients across the entire spectrum, from those who have died to those who have had a good recovery. We have welcomed their feedback at regular meetings that we convene in our lab to try to address these issues. But these are really complex issues for which there's no right answer. So we are actively considering all of these questions, but I certainly don't pretend to have all the answers.
I appreciate the honesty and sharing some of your experience both as a clinician and as a researcher.
I wanted to ask a little bit about if you prove this hypothesis and this strategy for assessing individual patients for individualized treatment, how would we be able to apply this in resource poor environments where these biomarkers and imaging studies are just not feasible in this way?
So another really important question that has both medical and ethical dimensions to it. So your point is well taken, that if patient selection for targeted therapies in this Connectome-based clinical trial platform requires advanced imaging techniques, then patients in resource-limited settings may not have access to these therapies. And unfortunately, it's not possible to map the Connectome with a CT scanner. So this type of approach will, at least for now, require a local MRI scanner. That being said, as we talked about before, the acquisition of high-resolution diffusion MRI data, that software, that sequence, it can be readily implemented on conventional clinical MRI scanners on the standard hardware that most hospitals have around the world.
And in kind of bringing this all together, we've talked about a lot today, from, again, these really sophisticated imaging protocols to using continuous EEG and other biomarkers that you'll be looking at as part of this study. In your mind, once you have this initial data from your phase 1 and potentially 2 studies, where do we go from here? Is the vision for, again, more of a phase 3 type trial, rolling it out to multiple centers that could potentially have this capability of processing this software? Or if IV methylphenidate isn't the answer, what do you kind of see as the future direction without giving away too many of your trade secrets?
So, I mean, basic principles, we need larger sample sizes, multi-center trials. We need randomization. Now, it's another medical and ethical issue is, are families going to be willing to sign up for trials like this if there is a placebo arm? If we start doing focus groups, if we talk to our patient family advisory board and they say, look, we don't think that that's appropriate because most families are going to want access to some type of therapy, then there are other trial designs that we might want to pursue. For example, a crossover trial design where each patient is his or her own control and you're randomized to a different sequence of drug, placebo, or placebo, drug. It might be that those types of trial designs are needed rather than doing the kind of standard randomized controlled trial with a placebo arm. But I think the basic principles coming first. If we are able to demonstrate that this drug is safe, and once we identify the appropriate dose, we need to make this a larger multi-center study.
It sounds very, very promising. And this overall approach looks like using really objective biomarkers and to have a really standardized approach to assess the connectome. And in my mind, the future involves combining all these things and in some structured way, perhaps even using machine learning or other approaches to integrate all this information to create these personalized prognosis and therapy approaches for TBI patients. It makes me think about, many times in the last decades, we've heard terms like personalized medicine, and it always feels very, very far away, very, very like, that sounds great, but how close are we to this? And I think the adjunct question is, will the basic clinical exam, fade away in prognostic value? Because I always teach our trainees, like that's what really tells you what's going on in the brain is, your exam, always go back to your exam. And it feels like we are maybe moving away from that, at least in terms of prognosis.
So to respond to your last question first about the bedside behavioral exam. So in my opinion, and it sounds like we are of the same mind here, the bedside behavioral assessment will always be the foundation of our prognostic assessments. And multiple studies dating back to Joe Giacino and Kathleen Kalmar's work from 1997, showing that early behavioral evidence of emergence from a comatose or a vegetative state to a minimally conscious state has a substantial impact on long-term functional recovery. And as many of your podcast listeners probably know, there was also a paper published in the New England Journal of Medicine from Jan Klassen's team at Columbia last year, showing that covert consciousness, or consciousness that can be detected with task-based EEG or functional MRI paradigms, but consciousness that is not detectable on the bedside exam, it also appears to predict long-term functional recovery. So it's possible that our bedside exam, while fundamentally important, may not be enough to make a fully informed prognosis. And I think this is what you were getting at in the first part of your question. So as you suggest, many leaders in our field are now advocating for a multimodal approach to prognostication that leverages data from a behavioral exam alongside conventional EEG and MRI biomarkers, as well as some of the advanced EEG and imaging biomarkers that we've been discussing over the last few minutes. And when we're considering this approach to detecting consciousness, which is directly relevant to predicting future recovery, it's important to point out here that the 2018 guideline that was endorsed by the American Academy of Neurology, the American Congress of Rehabilitation Medicine, and the National Institute on Disability, Independent Living, and Rehabilitation Research, as well as the 2020 guideline that was endorsed by the European Academy of Neurology, they both support this type of multimodality approach. So this is what these standard clinical guidelines are now endorsing. So in summary, I think we've come a long way from the days of prognosticating solely based on the admission Glasgow Coma Scale score and basic lab variables and a head CT scan, but we still have a long way to go. I don't think we are where we need to be when it comes to providing families with a fully informed, accurate prognosis about their loved ones' chances of recovery. And of all the different types of patients with brain injury that we treat in the ICU, I still think that patients with TBI have the most uncertainty surrounding their prognoses. And this is a major motivator for all of the research that's going on in this field, including some of the machine learning approaches that you alluded to.
Dr. Edlow, thank you so much. I think that sums up everything we've discussed very nicely. At the end of the day, this is about, as a clinician at the bedside, what do you tell the family? What do you tell the other physicians and multidisciplinary team taking care of the patient in these really high impact situations? So kudos to you and your team for the work that you're about to undertake with these trials. And we really look forward to hearing the results coming forth in the future. Any final takeaways for our listeners, Dr. Edlow?
Thank you so much, Dr. Kronfeld. I guess I would just end with a recommendation to acknowledge uncertainty and to express humility when meeting with families to discuss goals of care in the ICU for this population of patients with severe TBI. Even though I've tried to educate myself and read as many papers as I can and have been attending now for 6 years, I find many cases in which my prognoses are just wrong. And I just think it reflects how many unanswered questions there are in this field, how much there still is to learn. And my opinion is that there are very few cases where we can truly be certain about an individual patient's chances of recovery or lack thereof. And so I acknowledge when speaking with families that it's anxiety provoking to have that uncertainty. And I explain to them that I wish I could provide clarity, but I just don't think we're there yet. And I don't think that we have the tools to provide definitive prognoses, and we have to acknowledge the range of possible outcomes for each one of our patients.
Seems like whenever I talk to very experienced people in the field, they always say the same thing. They always say, first you learn and you get a lot of experience and you think you know what's happening. You think you know how to predict how someone will do. And then Giacino or David Greer, Jan Klassen, they all say the same thing. And then you realize that there's patients that really confuse you, and they come back walking into your office when you didn't expect it, and it really leans to trying to get a much better objective and confident approach to this. So we really appreciate the work you're doing, and really appreciate you joining us today.
Thank you, Dr. Kronfeld and Dr. Bauerschmidt, and thank you again to the Neurocritical Care Society for the opportunity to participate in the podcast.
Thank you for listening to the Neurocritical Care Society podcast.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care On Call is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care On Call, visit www.neurocriticalcare.org/on-call. Use promo code PODCAST for an extra 10% off your subscription.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tarek El-Maghribi, Andrew Bauerschmidt, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Kassi Kronfeld, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threkold, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.